Okay, well, today we're going to talk about just a few studies and how different things fit together in terms of CT and nuclear, etc. And so I'm going to just go through some cases. This is a 79-year-old gentleman, history of AML, chronic respiratory insufficiency, past medical history, significant for a lot of risk factors. Patient had runs of non-sustained VT. During a sleep study, was admitted for observation, negative troponins, had a 2D echo with a low EF, regional wall motion abnormalities, no significant valvular heart disease. And you can see these images here. Anyone has any idea or interest or knowledge of what these images show? Mohammed, since this is a fellow session today, but I don't have a fellow, so I'm going to ask my one and only fellow there, what do you think about these images?
Well, I would assume stress on top and rest.
Well, this is okay. So this is stress and this is rest. Okay, from the apex up to the base. So this is the horizontal long axis, the vertical long axis. So, what do you think?
I mean, there's possible some inferior.
Some who?
Wall, some inferior wall perfusion that looks kind of similar between rest and stress.
Okay, so it looks like there's maybe a fixed defect inferiorly here, right?
So
that's suggestive of coronary disease. Now, you know, we always run into these issues of whether this is diaphragmatic attenuation or whether this is a real defect. And I want to just bring up the issue of prone imaging, because sometimes, and we didn't do it in this patient, but sometimes when you do prone imaging, you can actually help determine whether a defect is real or just artifact, okay? And so the way we do that is we do supine imaging first, and you can see in this particular case, on the supine images, there's a little bit of decrease inferiorly here. And on the prone images, now you see that defect goes away. And in fact, when you look at the raw data on this patient, you can see the patient actually did have significant diaphragmatic attenuation. And what we do also, and the polar maps didn't show much. So what we also do is you can see here, this is again this is the supine images and the prone images, and you can see the improvement here from supine to prone. So a lot of times this can help prevent you from having to do rest imaging, for instance. You do a supine image and the defect goes away with prone, you say, look, it's just artifact.
How do you do the prone?
You do actually lie them on their belly. Instead of on their back, they're now on their belly. And that shifts the diaphragm. And it also shifts, you know, if you have breast attenuation, I'll show you another case of breast attenuation, it shifts different breast positioning, etc.
So there are some other cameras that actually work in the sitting position, like DigiRad, for example. So being in the sitting position, would that actually reduce this artifact or make
No. No, the same position doesn't. Actually, it's best to change you have to change the position, because it's when you lie down flat, your diaphragm tends to come up.
Right. So
right. If you're sitting in a chair, that can somewhat. So upright imaging can also help in terms of lowering the diaphragm. But remember that the heart sits kind of in the belly of the diaphragm. And so if you still have the upper edges up and the heart sitting in the belly of that diaphragm, you're going to get still that same artifact. So the best way to really kind of see if it's real or not is to change positions. Defects that change with positioning are not real.
Right.
Okay, that's a take-home message. Now the other take-home message from this is to always look at the ejection fraction. And if you look here, you can see this patient has normal ejection fraction, right? So if the patient had abnormal ejection fraction, that would be a tip-off that, look, this is some actual problem, prior infarction potentially, etc. But the fact of having normal wall motion, normal regional wall motion in the areas particularly of where you have a potential artifact that clears, that would indicate that this is artifact rather than real. Let me show you another example. This is a patient who you can see here has an anterior defect.
We can't see the pointer, Dr. Mahmarian.
I'm sorry?
We can't see the pointer.
Oh, so anyway, you can see there's breast attenuation here, right? You can see the breast shadow. Yeah, how it is here in the breast shadow. So this patient looked as though this was probably breast attenuation. So we did supine on top, and we did prone on the bottom. And notice that the anterior defect seen here is now completely gone. Okay? And again, if you look at the ejection fraction, you can see that the ejection fraction is entirely normal. Okay? So this is artifact, and this is a great way, without having to do CT attenuation correction or line sources, which really suck anyway, by doing this, very easy. Just no new software, no nothing, just flipping the patient. You can really increase your likelihood of doing stress-only imaging. Yeah.
But this has to be done on-site with the patient there.
Well, yeah, the patient has to.
Which means you depend on very astute, good technicians that will pick this up.
Well, yeah, I mean, I don't know if it's very astute. I would say that anyway. I would say that if someone sees a defect on the first study, they should flip them over and put them prone and see if the defect goes away.
I would be willing to bet a bottle of wine that this doesn't happen in most places in the street.
Well, again, it's a matter of education and such like that. All right. So let's go back to this particular patient. Now, we already said that we weren't sure whether this was a real defect or artifact. This patient actually had stress in rest, okay? But you'll notice that the inferior wall really does not thicken normally, okay? So unlike the other studies where we were looking at prone, where there was normal regional wall motion, this is abnormal regional wall motion. So now we're thinking the patient could potentially have something in that right coronary artery distribution in terms of either hibernating myocardium in that area due to ischemia or after being stressed, or having an infarct potentially, okay? And you can see here that the defect size was 15%, and it was all in the right territory. The EF was low, the ventricle was dilated, and the study quality was fair because of motion artifact, but you can see here also there is some diaphragmatic attenuation as well. So in this regard, the patient then went on to have a CT scan to see if the ordering physician wanted to have clarity on this point. And so we did a CT, and you can see that the patient does have some calcified and non-calcified plaque, but this is all non-obstructive, okay? And you can see in the right coronary territory, which is where the perfusion defect was, the right coronary artery shows no significant stenotic disease at all. In fact, very minimal plaquing, okay? So this is a patient who has basically non-obstructive coronary disease with a low EF and regional wall motion abnormalities. And if you look at this in terms of wall motion, you can see on the gating. Let's see if we can do the gating here. You can see that compared to the rest of the ventricle, the whole ventricle doesn't contract normally. But notice the inferior wall here, which contracts very, very poorly. Okay, so it's worse than the other walls. So what this actually turned out to be in terms of that abnormality on the SPECT study was actually more of a partial volume effect. Now, does anybody know what a partial volume effect is? No, nobody knows what a partial volume effect. Okay, so the bottom line is that when you do imaging, and you look at just a static image, you're looking at the entire cardiac cycle, right? You're looking at systole and diastole, right? And if you have abnormal wall motion, when the myocardium contracts in the normal areas, it gets much brighter, right? And when it contracts abnormally, it's going to be less bright. Correct? Correct. And so remembering that the static image is a component of both the systolic, diastolic, isovolumetric, all the phases that in the R-to-R interval, you're going to have less counts, relative counts, in an area where there's less regional wall motion or diminished regional wall motion as compared to areas where there's normal wall motion or better preserved wall motion. And so this was simply a partial volume effect in someone with non-ischemic cardiomyopathy due to regional wall motion abnormalities that caused us to say that we thought there was a defect in the right coronary territory, but indeed that was not the case.
Shouldn't you see this then a lot, very often, in people with regional?
Well, it's something that we always, whenever you see someone who's got regional wall motion abnormalities, and I mean in someone who's got already diffuse hypokinesis and has regional, and has, as you know, many of those patients do get varying wall motion abnormalities in different regions. Yes, we always think about that, and and that's one of the reasons why we called the physician. We thought there was probably non-ischemic cardiomyopathy.
It would be a fixed defect, right? Because
I'm sorry?
It would be a fixed defect because you would have it on both rests.
Exactly. It's still a fixed defect. That's the problem. You still, because the wall motion isn't going to change one way or another, so it's still a fixed defect. And in this patient, we couldn't be sure whether it was really non-ischemic cardiomyopathy or the patient had non-ischemic cardiomyopathy plus, coronary disease. That also happens. But obviously, based on what we saw from the rest of the scintigraphic results, it doesn't look as though the ejection fraction reduction could have been due to extensive coronary disease because the defect was very small. Okay? So based on that, we tried to get clarity. And clarity was done by doing a CT. And I just want to emphasize that CT is actually a very good way to get at this problem and clarify the images. Now let's look at this patient. This is a patient, 58-year-old woman with left-sided chest pain, has multiple risk factors for coronary artery disease. She's on hemodialysis. She had a 2D echocardiogram with a terrible ejection fraction. The RVEF was depressed. There was no significant valvular heart disease. And again, in this patient, I hate to keep, Dr. Solomon.
Yes, sir.
You're here. You've done CT and nuclear. So what do you think about these images? This is stress, and this is rest. Okay. So what do you think about that?
From here, I don't see any significant defect.
Okay, so it doesn't look like there's any significant abnormalities in terms of perfusion abnormalities.
There may be an element of RV.
There may be a little bit of reduction inferiorly again. You have to wonder whether that could be also some diaphragmatic attenuation. Anything about the thickness of the ventricles?
Both ventricles are thick.
Okay, so both the right ventricle and the left ventricle look thickened here. Okay? And what about let's look further at this. Let's look at the wall motion. What do you think about the wall motion? Okay, so it's hypokinetic. The ventricle is moderate to severely hypokinetic, consistent with what we would have seen on the echocardiogram. And you'll notice that the right ventricle also is kind of hypokinetic, right? It's not moving very well. All right, let's go further. We got an EF of 31%. End diastolic volume was severely enlarged for a woman. It's 180 milliliters. What do you think about the images here? Anything unusual about the raw data?
Breast attenuation.
You think that's breast attenuation?
Right there, yeah.
Pericardial effusion.
Huh?
Pericardial effusion there?
Pericardial effusion. Why do you say that?
Well, there's the hallowness surrounding the heart, and it looks...
Yeah, there's a circumferential blackness that's photopenic, right, around the heart. And in fact, that would be highly suggestive of a pericardial effusion. So indeed, the patient went on to have a CT because it was, again, the question of whether this was really a non-ischemic cardiomyopathy or ischemic cardiomyopathy. And the patient did have a circumferential pericardial effusion. And the patient, as it turns out, had non-obstructive coronary disease. And as you can see from the EF, both the left side and the right side were moderate to severely hypokinetic. The right ventricle also is not moving well here at all. And you can see this circumferential pericardial effusion. So this was a case of non-ischemic dilated cardiomyopathy. The patient had a moderately large circumferential pericardial effusion. The EF was depressed with LV dilation, etc. Yes?
John, this is a great case
Yes.
to generate a discussion.
Yes, that's the whole point.
Yes, because the thing is, when you have somebody with a lousy LV, when you try to decide ischemic, non-ischemic, wouldn't it be more cost effective to just go straight to the CT?
Yes, and that's why. This is why. Because if you look at the data.
We're doing 2 tests, 2 expenses, and at the end of the day, you still have to do the CT.
True, and we
Why
didn't,
not
because we didn't order the study.
bypass the nuclear and go straight.
I agree. I mean, I totally agree with you. I mean, if you look at the data with CT, there's 99% sensitivity and 96% specificity with a negative predictive value of almost 100% for excluding coronary artery disease. So in people with low EFs. So yes, I totally agree with you. In someone where you really want to know, is this non-ischemic or ischemic? Do a CT. Now, the only problem, the only caveat to that is if you do a CT and there's 50% here and 70% there, and then you don't know. But so you have to be, so when you look at these things, it's really the negative predicted value that's so important, not the positive predicted value in terms of looking at disease, right? But absolutely, if you want to exclude disease and say this is non-ischemic, this would be the best way. It's doing a CT. Yeah. Because honestly, with nuclear, when you get a lot of these regional wall motion abnormalities we showed in the last case, you have a lot, there are so many variables that go into why someone might have a perfusion abnormality. Besides attenuation artifacts, you have the partial volume effects, which we already talked about. And so then you're left with, yeah, I think it probably is. But how does that help the doctor, right? You say, oh yeah, I think it probably is. Wouldn't it be better to be categorical and say, it's clearly not, you know? So yeah, yeah, absolutely. John?
There was no perfusion on the echo that they got?
I'm sorry?
You said there was an echo, right, on this patient?
The echo was not done in temporally close to this.
Oh, okay.
So this was actually a new finding on this patient. And we just had a case about 2 weeks ago where we also picked up a rather large, I don't know if you were there at that time or whatever, but anyway, a rather large pericardial effusion. And it's something we don't often see on when we look at the raw data, but again, it's a reason why you should always review raw cine data. Because not only does it help you in terms of deciding whether things are real or not real in terms of artifacts, but you can also pick up a lot of other things. Breast tumors, lung masses, liver masses we've picked up before, you know. I picked up an echinococcus cyst one time in the liver, all kinds of crazy things, you know, and of course pericardial effusions and things like that. So you should always look at the raw data, always, okay? All right, let's go to another case. This is a 62-year-old man with chest pain and shortness of breath. Let's see, Omar, what do you think about this case?
Not done nuke yet.
Yeah, but you've seen images before.
Yeah.
Come on. Those, you know, what do you think? This is stress, right, and rest. So what do you think?
I think it looks pretty equivalent.
Looks pretty equivalent. I would agree with that. I would actually agree with that. It looks pretty equivalent. This guy was previously healthy, exercises an hour and a half a day. He had recent onset of dyspnea on exertion and chest pain. And that was while climbing stairs, and he came into the hospital. His physical exam was normal. His troponins were negative. What do you think about his wall motion?
So maybe some inferoseptal
Hypokinesis.
Yeah, I mean, the wall motion looks actually pretty good. Let me ask you this: what do you think about the right ventricle? Let's ask Mohammed, because he's seen a lot more of these than Omar has. What about the right ventricle?
It appears dilated and
Yeah, it certainly looks dilated, doesn't it?
hypokinetic.
And it's hypokinetic, and it's not particularly thick. It's not particularly thick. It's just dilated and hypokinetic. Now, sometimes in people with severe right ventricular hypertrophy from long-standing idiopathic pulmonary hypertension, they get extremely thick and bright right ventricles, almost to the same degree as the left ventricle, okay? So this is really a very mild increase in right ventricular count, so to speak. But the ventricle is clearly acute. Well, I don't know if it's acute, but it's clearly dilated and it's hypokinetic. So when I saw these images, I actually called the physician who was taking care of this patient. The ejection fraction was 64%. What would you be concerned about, Mohammed? I called the physician. I said, look, I think you need to be concerned.
PE.
Yeah. So that was my concern, because the guy came in with chest pain, shortness of breath. The perfusion looks normal. Okay, the right ventricle is big. It shouldn't be big. It's not particularly thick, which would indicate this was an acute process of having hypokinesis and volume overload. And this is just the raw data, which really doesn't tell you much, but I think you can see the right ventricle here as well on the raw data. And so normal perfusion, a little bit of diaphragmatic attenuation. So we went ahead and did a CT on him. His CT showed normal, basically normal coronary arteries. I mean, no plaquing at all. There was a little myocardial bridge there, which we commonly see. People make a big deal out of myocardial bridges. We see them all the time. And I tell you, no kidding, I saw a 25-year-old who had bypass for a myocardial bridge. About a month or so ago. We couldn't believe it. The graph was open, but yeah. No significant coronary disease. So then we can look at this instead. This is now looking at the axial data. The pulmonary artery you see is dilated, right? And what else do you see? You see these big clots.
Yeah.
All right. So the guy had multiple large pulmonary emboli. And again, a tip-off on the nuclear study was, like we said, when you do the CTs, a tip-off is always, anytime you see a dilated pulmonary artery, you should immediately look for pulmonary emboli, right? And in fact, there they are. There's a big one there, and multiple. I mean, guy had multiple pulmonary emboli, okay? And so, when you read studies, you should always be open to everything, right? You shouldn't just say, oh, no perfusion, done, finished, poof, okay? You should look at everything and evaluate everything. And when things don't make sense, why is that like that? You should really, investigate further and give that information to the physician who ordered the study, okay? So like a guy had large bilateral pulmonary emboli. Incidentally, pulmonary emboli are very well seen with CT. And there's actually pretty good criteria from the PIOPED 1 and 2 studies looking at when you do different things. And D-dimer tests are usually done when PE is unlikely. And if they're low, you can basically exclude the likelihood of PE. If they're high, then it's recommended you go for CTA to look and exclude pulmonary emboli. And in fact, if you look at the rate in people that have negative D-dimers, it's a very low rate of venous thromboembolic events. And in fact, in patients that have normal CT angiograms, it's also extremely low. And if you have a positive PE, obviously it goes up considerably. And I want to just emphasize that there are times when you get inconclusive studies. For instance, in this particular large series, which was rather a large series, there were still some patients who had incomplete or I should say inconclusive studies. And a lot of times that is due to the fact of the way the study was required. I'm going to talk about that in a minute, but I also want to emphasize that when you do CT, not only is it unlikely that you see pulmonary emboli, but you obviously many times pick up other things, okay? And in fact, you know, in this particular study, 33% of patients had alternative diagnosis to explain their symptoms beyond having pulmonary emboli. So CT picks up a lot of different things. And in this study also, 23% of patients had new nodules, masses, or adenopathy that required further evaluation. So CT has now become pretty much the gold standard. And I get back to this issue of being able to look at CTs. This is another patient who came in with shortness of breath and had a normal nuke, and they actually, this was a patient of Dr. Bergler who didn't believe the nuclear study. He said, I can't believe the nuclear study is normal. This lady's 85 years old. So he did a CT to look for coronary disease because he didn't want a Cath, and it turned out she had PEs. And it's very important when you do these studies that you do them gated. This is a non-gated study. This is a non-gated CT, okay, which is what radiology does all the time, okay? And although you may pick up large, pulmonary emboli if they're very proximal, believe me, when you look at these images, because of the blurring of and motion artifacts, you do not you can miss a lot of things. And when they're gated, they're just so much crisper in terms of being able to identify, even if you haven't timed the study to the pulmonary artery. Because many times, remember when we do cardiac CT, we're timing the artery to the arterial phase, right, to the aorta, not the pulmonary artery. But if you still have 150, 170 Hounsfield units in the pulmonary artery, which we had in this case, remember, clots around 50 Hounsfield units, so you can still pick up pulmonary emboli quite commonly. But it is important to gate these images to really get a very crisp look and be able to look at not only the whether there are saddle emboli present, but to look at the subsegmental levels in terms of abnormalities. And in fact, by the most recent, I was actually on this appropriate use committee panel several years ago. It's the ACR, combined ACR with many other societies, looking at the utilization of CT and other modalities in acute chest pain. And when you look at the issue of looking for pulmonary emboli, obviously if people are D-dimer negative, none of these tests, ultrasound, VQ scanning, et cetera, make any sense to do. But in people that are not high likelihood but still are D-dimer positive, CT comes out very high. And at their high likelihood, CT again comes out very high. So CT has now become really the gold standard for looking at pulmonary emboli, whether patients have it or don't have it. Yes, Mike?
So when the CT is inconclusive,
yes.
What's the other test?
Okay, so then people recommend, if it's truly inconclusive, VQ scanning, okay, as a secondary test. But most of the inconclusive CT scans, which represent 1% of all CT scans, are due mainly to the way the study was acquired. And if you have a gated study, it's highly unlikely to have an inconclusive study. I mean, you can look at the subsegmental vessels very categorically. The other thing I want to emphasize is that, going down to the subsegmental arteries, there's really no good data to say that those patients really benefit necessarily from treatment. So it becomes to a little bit of a catch-22 in terms of how much you want to identify or not, right? But certainly for looking at the subsegmental and the secondary and tertiary levels, if you gate these images, you should not miss any pulmonary emboli.
So why can't radiology gate?
They can. They just don't.
Because?
You'd have to ask them. I mean, most radiologists don't gate images, even though the literature out there would really say that it's the better way to do it. Most radiology departments don't gate.
So they have the technology. It's no big deal for them.
Yeah, they can do gating, but they don't do gating. Yeah, and we do gating all the time because it just gives crisper images. I mean, you have to remember that when everything in the chest moves, everything. I mean, it's not just the heart. The heart affects everything in terms of the pulmonary artery motion, everything. So the only thing that's actually stable in the chest is the descending thoracic aorta. And the reason for that is because it basically sits entrenched, basically on the spine almost, and is completely covered over by various mesenteric membranes, okay? So it actually stays pretty stationary.
Yeah, we see that with the DE. Only
Yeah.
It just sits there.
It just sits there, right? It just sits there. Everything else moves all over the place, but the descending thoracic, that's actually a board question, incidentally, just in case any of you take boards. But we're CT. But yeah, I mean, the ascending thoracic aorta, the arch, they all kind of go crazy. But the descending thoracic aorta, once you get back along the spine, forget it. It's immobile. You know, it just sits there. Okay?
Question.
And yes.
So in clinic,
Eric.
we sent you a patient, it was like 97-year-old lady. She had, my history was sounding like a PE, but because of her age, she had chest pain. We're also less concerned about coronary artery disease. As far as protocoling it, if we're, number one, our differential was PE, and number two was coronary artery disease, like how much contrast load does that patient get when they come to the scanner? Like what, like contrast volume are you giving? I know, we want to get left and right side instructions with the
Well, no, but remember that just giving 60 or 70 cc's of contrast, you'll have enough contrast in the pulmonary artery to be able to see it categorically, gated, as well as the coronaries. And in fact, those cases I showed you earlier were patients who actually had the scan timed according to the aorta in terms of the bolus, right? And yet we picked up those large pulmonary emboli because, again, clot is about 50 Hounsfield units, 40 to 50 Hounsfield units. So if you have 150 Hounsfield units in the pulmonary artery, you have more than enough attenuation coefficients there to be able to identify a clot. Yeah. So you don't really need to give a lot of extra. Sometimes in patients who we have extremely high suspicion, instead of doing a flush with just saline, we'll do a 50-50 mixture of flush and saline, and that can also increase the Hounsfield units in the pulmonary artery a little bit higher levels, like 250, which is also more than adequate to be able to see thrombus. Yeah. Okay, so anyway, as I said, CT is at this time the gold standard for looking for PEs. Okay, here's another man, no prior CAD, had dyspnea on exertion. This is a patient I actually saw in clinic for the first time. Without prior CAD, referred for evaluation of exertional shortness of breath, associated intermittent mild chest pain for the past several months that was really not necessarily associated with exertion. No shortness of breath at rest, no P&D orthopnea. All his shortness of breath was provoked by routine walking, generally sedentary. He had degenerative joint disease. Again, he had this funny atypical left-sided discomfort which came and went and was not associated with other kinds of classic symptomatology. But he did have a lot of risk factors, and he had a prior carotid endarterectomy as well. So he was on a lot of medications, as you can see here. His cholesterol was not optimally controlled. I mean, for me, we'll go into a little bit of this, but 89 is someone with probably peripheral vascular disease, etc. Not optimal. And so I sent him for a myocardial perfusion scan. So, Dr. Solomon, what do you think about that perfusion scan? And you better get this right because
Top is stress, second layer is rest.
Stress is on the top, rest is on the bottom.
So there's an obvious perfusion defect. Is that anteroseptal that you see between the rest and stress.
Okay, so there's an apical septal, an infraapical, a mid-anterior, a mid-anteroseptal, a mid-infraseptal, a mid-inferior, a mid-anterolateral, and the basal septum are all involved. The apex is clearly involved. The apex is basically out, right? And the rest imaging, what do you think?
LVH.
No, well, I mean, what do you think? Does the perfusion get better or not?
Perfusion gets better with rest, yes.
Yeah, so actually the study almost completely normalizes with rest imaging, right? So there are all your my little arrows for you. Okay, so the defect size was 63%. Okay? The green is the ischemic area, or what changed, all right? So 63%, 55% ischemia, LAD right diagonal, plus minus circumflex. So certainly LAD diagonal, right, and maybe, it's hard to know sometime with these lateral areas whether that could be circumflex or not. It's probably more diagonal since the LAD is involved. So what do you think about this? So the ejection fraction is here. And you can see that the ejection fraction at rest was 46%. Those walls, I think you'd all agree, are hypokinetic. And the ejection fraction at rest was 53%. So what do we call that? We call that post-stress stunning, right? So if you were to, Mohammed, what high-risk features does this patient have?
Well, multivessel disease.
Multivessel disease pattern.
Drop in their ejection fraction.
With stress.
Low ejection fraction.
And then more than 20% ischemia defect.
Okay, so large areas of ischemia, post-stress stunning. Okay, he's got almost every risk factor that we think about. And remember, this is just looking at data with a normal SPECT versus an abnormal SPECT. There's a 10-fold difference in event rates, right, in terms of death and MI. But what's important to remember is that size matters, right? So the larger the perfusion defect, the more likely you are to have an event, okay? This has also been shown with rubidium PET imaging. This is looking at 0% abnormal myocardium up to greater than 20%. And you can see the incremental increase in cardiac death, in terms of cardiac death, and also all-cause mortality as the defect size gets larger, right? We also know there's an interaction with ejection fraction. This is data from many years ago with Dan Berman, showing that a normal myocardial perfusion scan, mildly abnormal, moderately abnormal, or severely abnormal, if the ejection fraction is less than 45% post-stress or greater than 45%, look at the difference in event rates in terms of cardiac death in 1 year. Okay, our patient was right on the teeter-totter. He was like 45, 46% EF. So again, you can see the importance of ejection fraction. There's also clearly an interaction in terms of the size of the ventricle post-stress. If you have a dilated left ventricle post-stress, that also is a risk factor, right? And there's also this issue about regional wall motion. So this is a large cohort of patients getting both either exercise or pharmacologic stress, no ischemia, normal wall motion, very low event rate in terms of hard cardiac event-free survival, either ischemia or abnormal wall motion, and both ischemia and abnormal wall motion. So you can see that it's not only the ejection fraction, it's also the presence of regional wall motion abnormalities that do help predict outcome. Now, this slide has been shown many, many times. It's Dan Berman's data. It's Hakamovich who put this together many years ago, where this was all retrospective data. But it does show there seems to be an inflection point around 10% ischemia, where you tend to see an increase in event rates with medical therapy as compared to revascularization. Whereas when you get below 10% ischemia, it appears that people do worse with revascularization than do with medical therapy. Okay? We have also seen this in our post-infarction study, INSPIRE, where we basically show that once you have over a 20% defect, you see an exponential rise in events. And once you get more than 10% ischemia, you see an exponential rise in cardiac events. And so it's been shown consistently across studies that over 10% ischemic defects and over 20% total defect sizes tend to be an inflection point where you start to see major events as compared to no or minimal events at lower levels, right? And in fact, as you all know, there is a trial going on now called ISCHEMIA, which is actually using CT to exclude left main disease, and then taking patients who have certain criteria based on the size of perfusion abnormalities or by stress echo, etc., to see if revascularization does better in those patients versus intensive medical therapy alone. So ischemia is going to take a while to do, but you know, it's all based on this idea that patients with large defects probably do benefit more from a revascularization approach than patients with small defects. Now let's go back to our patient here. Our patient actually went and had a Cath because he had a 63% ischemic perfusion defect. And if you look at the Cath results, you can see that this is the LAD here. You can see that the LAD is basically amputated here. There's maybe about a 50% stenosis in that first obtuse marginal. And this is another view here. You can see the LAD. You don't see any distal vessel at all here, right, on Cath. And again, he had a moderate lesion in the right. Yeah, I mean in the OM. And the right, there was actually a lesion down here, a moderate lesion in the PD, and you can see that there is some collateral filling, some faint collateral filling of the LAD, but not very good. Okay. So the question arose then, you know, the patient has subtotal versus total occlusion of the proximal LAD, poor distal filling. Dr. Lowry was contemplating doing bypass on this patient, but he really wanted to know what the size of the arteries were before he went in there and tried to bypass the patient. So the bottom line is that we went ahead and did a CT. And you can see this is the LAD, this is the LAD lesion here, proximal. But look how nice you see the distal vessel. And this was actually a fairly large vessel. It was a 2.2 millimeter artery. It had no calcification in it. So it would actually be a very good artery to put a Lima graft in. And by the Cath alone, it would have been very difficult to be able to determine that. And CT is more and more being used to look at arteries that aren't well visualized distally on catheterization.
So what is the technical explanation for this?
Yes.
I mean, you're injecting directly in an artery.
Yes.
You barely see it. You're infusing dye intravenously, and you see it beautifully.
Yes.
So what's the technical explanation?
Okay. Well, part of it is because remember this is a how do you say it, an equilibrium study. So we've already gone through the venous phase of everything when we do these things. So you're already getting some collateral filling distally. And remember that we have the advantage on CT of having surrounding fat. Okay? So whatever we see in the artery is going to have higher Hounsfield units than fat, which is minus 60 Hounsfield units. So we have the artery, which is going to be around 50, 70 Hounsfield units, and we have the background tissue minus 50 Hounsfield units. So we see it beautifully. We see the margins of the artery beautifully. Even if there isn't a heck of a lot of contrast in there, we're still going to be able to see the artery very, very nicely. Look at what we see just on calcium scores, right? Without any contrast, we can still see all the distal arteries. Why? Because they're surrounded by fat, right? So we're able to see that very nicely. This was the circumflex, the OM. As you can see, there is about a 50% lesion there. And just to refresh your memory, there was this lesion here on the invasive angiogram. So moderate stenosis. And again, to refresh your memory, there was a lesion in the right. This is about a moderate 50-60% stenotic lesion. And again, you can see that was also seen here. Whoops. Here, it keeps moving on me, on the cine angiogram. So this patient went ahead and had 3-vessel bypass, and actually he's done extremely well. He had post-surgical pericarditis and etc. But he was on colchicine and aspirin, did extremely well, and is doing extremely well now. The other thing is he did have a prior procedure done. As you can see, this was a aortic graft that he had done. So he actually had an aortic. He never even knew. He couldn't even tell me what exactly he had. But he said he had some kind of peripheral vascular disease. So when we did the CT scan, we went ahead and did his belly too, and he actually has a very nice aortic graft from here to here for an infrarenal aortic aneurysm that he had in the past. And not to be remiss, the patient also, as everyone with a pulse, had an echocardiogram. So his EF by echo, you can see, was extremely normal, normal chamber sizes, no significant abnormalities. So this was I think it was a very nice case of where you can integrate different techniques to get a better feeling of how to treat someone. Yes, John.
Is there any like validation data for looking at the distal vessel like that to say whether the outcomes are better?
You know, there are some data looking at chronic total occlusions, but it's very preliminary data. We've been looking at this quite frankly, you know, all along, because CT is such a robust way to look at collateral blood flow because of the equilibrium phase and the fact of the surrounding tissues. So, but you know, it's something that requires more publication because there really isn't a lot of data out there yet. Yeah, it would be a good project for a fellow actually to kind of look at that. All right, let's go on. We still have some time, so let's look at this. This is a 75-year-old asymptomatic man with a history of diabetes, hyperlipidemia, and hypertension. The patient had a CTA, and you can see he has plaque, a lot of calcified, some non-calcified plaque in the LAD. Distal artery looks fairly good. You can see in the second, this is the circumflex, this is the second obtuse marginal, so the circ looks pretty good. But he had this high-grade lesion in the right coronary artery. And because of that, he had a myocardial perfusion scan. And the myocardial perfusion scan was basically reassuring. It was normal. There was a little bit of diaphragmatic attenuation at the base, and that is actually seen quite nicely on the rotating images, like right here. You can see a lot of diaphragmatic attenuation. And so this was also a patient of mine, and actually he exercised pretty good. He had 9 minutes on the Bruce protocol, 10 METs, no ST changes, no angina. And again, he had a good ejection fraction, and he just had some diaphragmatic attenuation. So I treated him medically, and this was his initial lesion, and this was back in August of 2013. He had a total cholesterol of 158 and LDL of 93, not terrible. He was then treated more aggressively, and he had another CT in 2015, which is about a year and a half later. Now his LDL is 52. And I want you to look at the change in the stenotic area here as compared to here. Okay.
Was there any progression anywhere else?
I'm sorry?
Was there progression?
No, he had no progression at all.
Okay, so everything.
Everything, yeah. I mean, but this significantly went down.
So how do you know that's real?
Ah, okay.
In other words, what reproducibility data do we have with CT? So that
Well,
we can know when something changes, it's real. I mean, obviously there's some dramatic changes. But when you have a change like that, how do you know it's not technique versus?
Okay, we'll get into that in 1 minute. That's a good question. Reproducibility, serial imaging is very important. This is another patient of mine. He had hyperlipidemia. He had a recent, well, it wasn't recent anymore. This is in the past. Had an echocardiogram suggestive of an aortic aneurysm, so I sent him for a CTA. He had an LDL of 210. He had a prior calcium score that was actually 0 about 2 years earlier. I really was uncomfortable with this, but he refused statin therapy. And he had a CT, and it showed actually a moderate lesion in the LAD. It was non-calcified, okay? So we do see this from time to time. Subsequently, he got placed on statin therapy. His LDL went down to 60. He was on rovastatin, 20 milligrams a day. And now you can see that the lesion he had here is almost completely disappeared. Same image, same, profile. It's important to recognize that there's actually a lot of data out there about reducing atheroma. Most of it is actually done with IVUS. But there's a lot of data showing that as the LDL goes down, the percent change in atherosclerotic plaque volume also goes down with it. Obviously, there's a lot of secondary prevention data also showing that as the LDL goes down, survival improves or event rates go down. And there's actually a lot of prevention data. So all of it actually fits pretty nicely together in terms of this reduction in plaque and improvement in outcomes, although there are probably many other reasons why patients do well on statins besides the fact that they reduce lipid-rich plaque. You're all familiar with the Jupiter data, which is basically showing the same thing in an asymptomatic population. If you look at patients who are high risk, had high CRPs, were randomized, stayed on placebo, versus getting their LDLs down with rovastatin in this trial, significant reduction in event rates, and particularly in those with LDLs 50 or less. Okay? And that's, again, in an asymptomatic population. Pretty impressive stuff. There's also data now looking at serial CTAs. And again, this is initial data, but it's kind of interesting. This is looking at patients taking fluvastatin versus control. Okay, and this is looking at low attenuation plaque. So what you'll see here is that there's a total plaque volume goes down. And this is all driven by a reduction in low attenuation plaque, okay, which is that highly lipid-rich plaque, which you can see there, okay? This is one of the first studies that was done and published in JACC Imaging in 2010. Subsequently, there's been this other study by Matt Budoff, which has also looked at this, and this is looking at a group of patients who had serial CTs. They had either no prior history of coronary disease, but they had a CT for chest pain symptoms, etc. And what you'll notice here in the patients who were not placed on statins, low attenuation plaque didn't change, non-calcified plaque overall didn't change, and calcified plaque really didn't change much over time. In the patients who were placed on statins, there was a significant reduction in low attenuation plaque as well as total non-calcified plaque with a slight increase in calcified plaque, and that's been actually described by other people as well. Now, so statin versus no statin, low attenuation plaque and non-calcified plaques appeared to be most affected by statins as compared to not being on a statin. There's also some data from Hulton that was published looking at who might benefit the most from statin therapy. And this data was also published in CERT Cardiovascular Imaging about a year or two ago, showing that in patients who had more than 4 segments that had involvement of atherosclerotic plaque, that those on statins seemed to do significantly better than those who were not on statins. So it would appear that the greater the amount of atherosclerotic plaque present, the better people do on statins as compared to non-statins, not having been on a statin. And again, you can see this was non-significant in those with very minimal amounts of plaque present. Again, remember the follow-up here is relatively short. So that's not to say that people who have still mild plaque shouldn't be treated. But in the short term, it didn't seem to have much of an effect in terms of outcome, okay? There's also a lot of data using nuclear imaging looking at statins, and this is using PET data, and this is looking at various types of statins and et cetera being used, showing you can reduce perfusion defects, when you use serial myocardial perfusion imaging, PET. There's also many data, and this is, again, SPECT data, and this is looking at lifestyle changes and statins, pravastatin, simvastatin, et cetera, over the years that have shown significant reductions in perfusion abnormalities when you put people on statins as compared to not being on statins. This is interesting. This is just one example of a patient of mine who had a large perfusion defect in actually a first septal perforator, was put on nitrates, and had complete resolution of his perfusion abnormality. So we can see this with serial imaging. This is a very interesting image that was sent to the New England Journal by Ron Blankstein, who's coming actually this week to talk to us, visit with us, of a 42-year-old man who had exertional chest pain. His scan showed ischemia here in the lateral wall, consistent with circumflex. He had a lot of circumflex disease here, as you can see on initial CT. And because he had a relatively small defect he was aggressively treated with different medications as well as ezetimibe and a statin. And then 4 years later came back with atypical chest pain, and so they repeated the nuclear study, and the nuclear study now is completely normal. And look at the change in the area of the circumflex in terms of improvement, in terms of reduction in atherosclerotic plaque burden. So there's becoming more and more information being defined. Now, Dr. Quinones brought up this important question of reproducibility. So my answer to you on that is that software programs have still not been optimized in terms of looking at total atherosclerotic burden. In terms of looking at specific regional plaques, yes, but not in terms of looking at atherosclerotic burden. But what is generally speaking done, like the article by Zeb, is that whatever the software program they use, it's reproducible. Yeah. So you go from one study to the next study. Now, it may not be necessarily accurate, but it's definitely reproducible as programs tend to be, right? So we're actually talking to Siemens about this because I think there are some very interesting ways we can improve our reliability of being able to look at plaque categorically by actually doing normalization of contrast, which is something we don't do on CTs routinely, right? Where you basically scale everything to a certain Hounsfield unit. Everybody's study is a certain Hounsfield unit. Right? And that could be easily done, just like we do in nuclear. I mean, every study is scaled to a certain maximal count, right? Which then it's 100 counts as the standard. Same thing with CT. You could do that, and that would improve reliability. But this is a growing area, and I think it's a very important one because people are wondering what is the reason? How is it that statins improve outcome? I think there are probably multiple reasons, but I mean, you can clearly see improvement in perfusion abnormalities on statins. That's been shown in many, many articles using SPECT imaging as well as PET imaging. And now with CT, we see maybe the basis behind that, whether this is improvement in vasomotor tone or lack of vasoreactivity as well as reduction in low attenuation plaque. These are all potential reasons why there might be improvement. But I think this is going to be especially with the low radiation and with CTs, this might be a very nice way to be able to track whether therapy is doing a good job or not. Whether you really have optimized your therapeutic approach to the best possible means for any given patient. So that's kind of the deal there. I mean, I guess I could talk all day, but it's 1 o'clock.
Question.
Yeah. I have about 8 or 9 more cases. If you want to go through them, I'm here.
So when we talk about calcium scores, and you tell us that patients have a calcium score one day and they put on statin therapy, their calcium score may actually increase, right? But in that, it kind of seems the opposite, that you saw some calcium regression in that. So is that not like a...
Well, no, calcium didn't regress. Calcium went up. Calcium went up in the people on statins, but non-calcified plaque and low attenuation plaque, less than 30 Hounsfield units, which is that lipid-rich plaque, went down significantly. Okay?
One last scenario. Patient with chest pain, left bundle branch.
Yeah.
Should we bypass nuclear and go straight to CT?
I think CT, without a doubt, would be, if you have a low likelihood and someone's got, you know, a left bundle, I think that CT, it has close to 100% negative predictive value. The only caveat you get into is when you have all this, and you have moderate this and in 1 or 2 vessels, then you don't know. But I think in terms of overall specificity, it's a better test.
Insurance are already covering them easily?
I'm sorry?
Are the insurance covering them easily, or do we have to, or do we tell you, oh, you have to do a stress test?
No, I think the appropriate use criteria, if someone's got left bundle and you're looking, yeah. Because I think that's reasonable because it's a very good
It
test.
makes a lot of sense to me.
Yeah.
Question. Sometimes you get these
Alvin,
patients-
what?
Sometimes you get these patients with like atypical chest pain symptoms. You get a nuclear, and it ends up having like a 20% scar defect. Now, is there any way to differentiate severe ischemia or balanced ischemia versus scar, like looking at post-stress LV function or?
Yeah, so you know the issue of balanced ischemia. The issue of balanced ischemia, we talk a lot about it. But it's actually infrequent. And whenever people have a case where they've had an abnormality and you know they have disease, extensive disease, you know we recognize that happens 1 or 2% of the time. I mean, if you look at the data, and this goes back when I was a fellow and I published all this stuff. If you look at SPECT, in patients who have multi-vessel disease, 2/3 of patients will have multiple vascular territory abnormalities. So if you have double or triple vessel disease, 2/3 of those patients will have perfusion abnormalities in multiple vascular territories. 1/3 will not. And there'll be a very small number, if you look at people with triple vessel disease or left main, who 1 to 2%, who are not going to have perfusion abnormalities. It's going to be normal. Now, if you look at the data from Dan Berman, and he looked at a group of 100 patients who had left main and/or extensive other disease, who had normal perfusions, they looked at the perfusion patterns. And what's interesting is that if you take into account not only the perfusion abnormality, whether there is a perfusion defect or not, whether there's transient LV dilation, whether there's post-stress stunning, whether there's lung uptake, if you use all of these other regional wall motion abnormalities during stress, if you take into all these considerations, virtually everybody would be identified as being abnormal. Now, they're not necessarily going to have 20% defects, which you'd like to see, right, in someone with the left main. But almost all of those patients would be identified as being abnormal. Sometimes we actually see small perfusion abnormalities that we don't call because we think they're probably artifacts. In some of those patients, they may be disease. But when you read nuclear studies, you have to be consistent. There are rules, okay? If you stick with the rules, most of the time you'll be right, okay? Because one of the things that you don't want to have is that you call every little defect, and every single patient ends up you're having a CT or a Cath, and they're normal, right?
The other question that she was asking, which we periodically see, when is a fixed defect.
Yes.
Is it scar, or is it severe ischemia?
Okay, so that is an important question.
I can tell you what I do. If the EKG shows no Q waves, or if the echo shows no significant abnormality in that territory, to me it's ischemia until proven otherwise.
Okay,
That's
so
my practical clinical approach.
Well, I would say I would not use the ECG myself because I've seen too many people with like 30% defects who have normal ECGs.
It's not common. I will challenge you to show me all the.
Yeah, I'll show you. I mean, I'm always impressed by some of these ECGs and people that have these big defects. But I would absolutely agree if someone's had another test like an echo and they have normal wall motion and they have a fixed defect, I would say that's ischemia until proven otherwise. Because if we're saying there's a defect there, when I read and I think this is true with Faisal and Sumin also, we read more for specificity than we do for sensitivity. We don't like to overcall a lot of things. And there's a lot of artifacts out there. So if I call a defect, almost assuredly it's a defect. And if that patient has a fixed defect, and they have a normal echocardiogram, for instance, normal regional wall motion in that area, yes, I would say that you'd have to assume that that's ischemic. And the other thing that's interesting about that, if you look at those patients, what will you see angiographically? You'll either see a very tight lesion, okay, in the artery, or even more so, you'll see an occluded artery with collaterals, with very minimal collateralization, or not enough robust collateralization. And so that's one of the reasons why when patients have perfusion, I get all over the texts about this, but when someone has a stress image and they have a perfusion abnormality, they're supposed to give nitro to every single patient before they do the rest injection. Because we showed 30 years ago that by doing nitrate-enhanced rest injections, you markedly pick up ischemia.
A lot of sense.
Yeah, right? Remember when we did all those studies?
Sure.
Yeah. So I mean, nitrates are extremely important, extremely helpful.
Can robust collaterals normalize perfusion?
Yes.
Oh, yeah.
Yes. So if you have, so they're almost like bypasses. If you have robust collaterals and you give a pharmacologic stress, or you put someone on a treadmill, they may have absolutely normal-looking study. That's not a false negative.
So do we have?
That's a true negative. It's because they have adequate blood flow at rest and with exertion with the robust collaterals they have.
So would you say if we end up calling the perfusion study normal?
Yeah.
Would you say the same outcome data
Yes.
applies to that study as
Yes.
well? Like
In fact, I would say in someone like that, you know, they've already basically bypassed themselves.
The worst already happened.
Yeah, the worst has already happened. I mean, you can't get worse than 100% occlusion. The only time that is bad is if you have some guy or woman who has an occluded artery and they're receiving collaterals from a contralateral artery that, let's say, has 50% stenosis in it. Over time, it gets worse, and they maybe rupture a plaque, and then you lose that artery as well as the other vascular bed. That's where you get into trouble, right? Where you have infarction in the serving artery that's giving the collaterals to the other artery. And I had a patient like that. I remember a couple of years ago, a friend of mine, here was a guy, he had a 99, he basically had 100% occlusion of his LAD. He went 10 minutes on the Bruce protocol, had no ST changes, no symptoms, no nothing. But his scan, he had like a 30% anterior perfusion defect. And he had this subtotal LAD, but he had unbelievable collaterals to the LAD. But his right coronary already had like a 60% stenotic lesion. And I said, we're just going to dilate your you're going to do a stent your LAD, and just because I'm worried. I mean, if you lose the right, you lose everything. And lo and behold, because he was very non-compliant and everything, lo and behold, he came back. I see him, personally, but not as a patient. I say, you need to come in. So he finally comes in like 2 years later. He said, I've been having this funny chest pain. So I said, okay, we'll evaluate. Now he's got a defect in the inferior wall, and lo and behold, he occluded his right. And his stent to the LAD was still open. So if he had lost that, he would have been goodbye, Charlie. That would end the story. Yeah. All right.